Our next speaker will be Dr. Michael Sichlau, who will be from Chicago, who will be talking about the management of pleural effusions.
Okay, thank you. Well, this is not the most exciting procedure, but your presence here indicates that a lot of these, quote, unexciting procedures, when you dive deeply into them, there are some valuable things to remember and learn. And hopefully I can bring a couple of things that maybe weren't realized. Okay. I'm going to go very briefly over pathophysiology of a pleural effusion. This is pathophysiology that you know. These are basic procedures that you know, and the procedures I'm talking about today are the basic of the basic. And I'll go into a couple of more advanced techniques. Basically, pleural fluid, you can break it down into transudative and exudative effusions. Transudative are due to a systemic factor such as CHF or hypoalbuminemia, and exudative typically a local process such as infection or malignancy. The exudative effusions can be broken down into stages, and what's important is when you get to stage 2, you actually get a fibrin deposition into the visceral and parietal pleura. That becomes important when we start talking about intracavitary fibrinolysis. And of course, you want to get to somebody before stage 3 because then you have a fibrous peel and your success rate for getting rid of that's going to be much lower. And we have to have this Light's criteria. You don't have to memorize this anymore because there are apps for it. You can go to MD Calc and plug in the numbers and it'll spit out whether you have a transudate or an exudate. All right, so thoracentesis. I never thought I'd speak at SIR about thoracentesis, but typically, this is your transudative effusion, and honestly, I don't do much of these because the PA does them, but we're always around for them. I'll talk a little bit about positioning and equipment and approach, and my own personal endpoints, and also some evidence-based endpoints. What do you worry about with a thoracentesis? Well, pneumothorax, and this has been, as you can see, looked at pretty closely. Meta-analysis with over 6,000 patients found a 6% pneumo rate with thoracentesis. That was surprising to me. But then I saw that this includes ultrasound or non-ultrasound guided thoracenteses. And of course, as you would expect, the risk of pneumo is going to go way up when you're not using ultrasound guidance. There were some symptoms that were found in this analysis that they could correlate with development of a pneumothorax, such as cough, such as chest pain. Not the ouch, I have sharp pain in my shoulder pain, but more the dull pressure sort of pain, more of a visceral sort of pain. And of course, if you stick a needle in there and you